separating sickness. I'll try to keep it short for 5 minutes.
Good morning, everyone. I'll be presenting about the separating sickness on behalf of dermatology. So coming to this case scenario, I'll be starting the history from November of last year. Miss P, 21-year-old student from Andhra Pradesh studying CEC BTech in November 2022 had developed fever with multiple joint pain and rash. Fever was there for 10 days, high-grade intermittent and relieved with tablets and multiple joint pain. It involved bilateral knees, small joints in the hands and wrist associated with swelling. Erythematous rash present in the bilateral ankle region in the area of the ankle swelling, and there was no butterfly rash, oral ulcer, or other complaints at that time. She was seen in a nearby hospital and was diagnosed with SLE and was started on steroids in November 2022. After starting treatment, fever, joint pain, rash has settled. And again in January, while on steroids, she started to develop tender erythematous nodules in bilateral thighs, legs, and arm and wrist. She also started to develop bilateral knee pain and ankle pain and shin pain. And at that time also she had intermittent high-grade fever in the evening along with the new set of erythematous nodules during the fever episodes. The nodules resolved after 2 to 3 weeks with hyperpigmentation. So in January, she was evaluated by a rheumatologist outside and was started on HCQ, and prednisolone was told to continue at the rate at 5 mg, with which the above lesions resolved in 2 to 3 weeks time. So she was off medication from April 2nd week till the first week of May, when she developed recurrence of similar crops of lesion in the extremities along with fever and joint pain. At that time, she came to CMC for further management. So other history, there is no reduced sensation, paresthesia, or any wound in the foot, no difficulty in using hands or difficulty in walking, no epistaxis or redness in the eye. There was no other relevant medical family history or personal history. So the differential diagnosis considered with the history was syndrome complex of fever, joint pain, erythematous rash and nodules, SLE, rheumatoid arthritis, seronegative spondyloarthropathy, sarcoidosis, tuberculosis, and leprosy. So examination wise, there was no medrosis, no earlobe infiltration, no hypopigmented patches, no nasal or septal defect. Cutaneous examination showed multiple post-inflammatory hyperpigmented patch noted on the bilateral upper and lower limbs. And there was a well-defined ichthyotic patch with intact sensation in the left dorsum of foot extending to third and fifth toe. Pain and touch sensation was normal and carnage sensation was also intact. So CNS examination wise, the motor system and sensory system was normal. Plantar was bilaterally flexor. The patient had asymmetric enlargement of the right ulnar, median, radial cutaneous, common peroneal, and posterior tibial and sural nerves. And in the left side, she had left supraclavicular and ulnar nerves. So with the examination, this is the image that the patient had after the nodules is resolved with the post-inflammatory hyperpigmentation. With the examination, we went ahead with the investigations. We thought of leprosy. So investigation showed HB platelets total counts were normal. ESR was 28, CRP was 9.4, and ANA was negative and dsDNA was normal. C3, C4 was also normal. Other investigations were also normal. As for the lupus anticoagulant, it came as moderate positive, and for the IgM beta-2 glycoprotein and cardiolipin IgM came as positive. So biopsy, initially the patient was seen in rheumatology and was thought to have SLE because the outside reports had ANA and lupus anticoagulant positive. Because the patient was already on steroids, here also started on steroids. The patient was referred to dermatology for opinion for the same. At that time, the biopsy showed borderline lepromatous leprosy with erythema nodosum leprosum. And the skin smear done also showed 4+3+ positive in the other areas. So coming to the diagnosis was Hansen disease. So coming to the Hansen disease, it's called as great mimic. It can present in different ways. It's a chronic granulomatous disease by Mycobacterium leprae. It usually presents with cutaneous and neurological manifestation. Musculoskeletal manifestations are not common. So Gerhard Hansen was found out that Hansen disease in 1873, and this is the armadillo. Culture was not possible with the Mycobacterium leprae. So it can be grown in the armadillo, and this the endpoint of this disease is the patient will present with disabilities. So this is the incidence and prevalence in the India over the course of 1998 to 2020. In the recent 2007 to 20, it has come down in the annual new case detection rate and prevalence rate on the lower side. It is taken from Directorate General of Health Services thing. So the common presentation of leprosy is in all these presentation, cutaneous and neurological manifestations are the common thing, but the musculoskeletal presentation is not common. So I'll be presenting about arthritis in the Hansen's disease. So initially, the arthritis in Hansen's disease can be manifested in these 5 forms. It can be part of lepra reaction or acute symmetrical polyarthritis, tenosynovitis, chronic polyarthritis mimicking rheumatoid arthritis, Charcot's arthropathy. So literature review showed us that the lepra reaction and this chronic arthritis, Charcot arthropathy, and tenosynovitis, the patient can present as connective tissue disorder manifestation, but they found to have this Mycobacterium leprae because of the cutaneous manifestation that they have developed after they have developed this rheumatological manifestation. And so one of the case report where the patient is presented with bilateral large and polyarthritis with dactylitis, and she did not have other symptoms. ESR and CRP was high because of the painful nodules, and this biopsy showed Mycobacterium leprae, and the diagnosis was lepra reaction type 2. This is another case report with the similar history, erythema with no other presentation. The patient presented with rheumatological manifestation, initially diagnosed of pyoderma, but after giving antibiotics started developing this erythematous papules and plaque, which was found to have this Mycobacterium leprae. This is the other case report with the same presentation. So in all these 3 case reports, they were found to have this type 2 reaction, lepra reaction, presenting as rheumatological manifestation. After that, they were found to have this leprosy. So this is the other pure neuritic type of leprosy presenting as a rheumatological manifestation, where they have this arthritis, symmetric polyarthritis, tenosynovitis, and paresthesias. These are all the 5 case reports that has been shown. This is a recent case report where the patient was diagnosed initially with rheumatological condition. After that, they were diagnosed with leprosy in the time of 8 months, 2.5 years, 2 years, 5 years, 6 years, and 4 months. So this is another article. Our patient had lupus anticoagulant positive and this IgM glycoprotein positive. So the lepromatous leprosy part has this cross reactivity and antigen antibody complex mediated immune complex disease, which can have false positive serological markers, which can give us a false positive connective tissue disorder finding, but later it was found to have this lepromatous leprosy. So I'll be presenting short about type 2 lepra reaction. Type 2 lepra reaction is immune complex mediated reaction, erythema nodosum leprosum. It is mainly seen in the spectrum of lepromatous leprosy and borderline lepromatous leprosy. It usually occurs 6 months after starting MDT, but it can occur before the patient has been diagnosed with leprosy or before starting treatment also in 1/3 of the patients. The patient can have 3 manifestations. The initial could be cutaneous or rheumatic, or the patient can have both. In the severity of the erythema nodosum leprosum, systemic findings can also be seen. These are the systemic manifestations. So our patient had joints involvement, polyarthritis and arthralgia. The patient did not have any lymphadenopathy, no eye involvement, no organomegaly, no genitalia involvement, no kidney involvement. Bones, the patient had bilateral shin pain, so we thought it could be because of the periostitis of the tibia. Muscles was not involved. Nerves, our patient have multiple thickened nerves, so we thought it could be nerves involvement also. So case definition wise, it could be new occurrence, new erythema nodosum lymphosum, or acute, recurrent, and chronic. So our patient had recurrent erythema nodosum leprosum because the initial in January she had presentation. After that, it resolved with steroids, and again in May first week she started to have this presentation. So our patient has recurrent erythema nodosum leprosum. The diagnosis of borderline lepromatous leprosy. She was started on steroids 0.6 mg per kg and MDT. After that, the joint pain has reduced, fever has come down, and definitive management is thalidomide because she's not married. We have not planned for it so far. So the summary, in leprosy, these are all the manifestations that could be presented in spite of this no cutaneous manifestation. It could be they could be having tenosynovitis, thickened nerve, symmetrical polyarthritis, enthesitis, tender subcutaneous nodule, and as a part of a lepra reaction before they have been diagnosed with leprosy. So the learning points: lepra reaction can occur before starting treatment. Rheumatological manifestation can be a part of lepra reaction, and the initial presentation as a leprosy can also be a rheumatological manifestations. Thank you.
Thank you, Brightlin, for the presentation. I will invite Dr. Dia to comment if you have any. Thank you for being with us today.
We often miss leprosy because we don't know that it can present in all these ways. So this was just a sensitizing presentation. This patient is actually treated in rheumatology, and we've had a couple of patients recently who have been treated for their arthritis without looking for the underlying cause in terms of dermatology, so leprosy. So a couple of patients were treated for 3 or 4 months, and then once the nodules came, they were sent to us and we evaluated. So it is easy to miss it because this patient also didn't have the nodules when she presented. There was only a post-inflammatory hyperpigmentation. But if you could just send them over to us and think about this as a dimension to send them to us, we'll be happy to screen them. In lepromatous leprosy, it shouldn't be missed.
Thank you. There are no further questions. I have the.
We had one patch, but actually, even when we checked in the OPD, check only with ballpoint pen. So this patient, once we did the HR assessment and we checked with the semi-spine filaments, they found that there was a hyperesthesia there. We also do only food measures in the OPD, but we found that patch and we could send. And then, so that would have been the early manifestation because she wasn't really progressing the leprosy. She would have been tuberculosis between blood. She picked up early as possible. Even if you are neuritic, you can have an arthritis. So that is another thing to think about. We can experiment only neuro and rheumatic manifestations without anything else on this. There you have to do a normal
Thank you very much to all the 6 presenters. I would like to commend Dr. Rizwana and Dr. Prem Ragul for good presentations, inviting slides, and touching on multiple aspects of clinical medicine that are important. But at the end of it, the prize goes to a very concise, clinical, clear, and contextual presentation. That came the last. I give it to Dr. Brightlin. We'll meet you again next week. Thank you.